And Anna for inviting me again. And I'm going to speak about dermal filler blindness. I'm going to look a little bit at the history of where we are and how we got there. And this is something that we've been looking at for the last 20 years. That's me, my biography. So if we just look first at how it happens, there's 4 different mechanisms. Obviously, on A, you can hit the cutaneous branches, in this case, supraorbital. The second thing is you can hit a remote site through anastomosis. You could be unfortunate to have an AV shunt in C in the glabellar area, or obviously in the orbit between the ophthalmic artery and vein. So this is the geographic distribution of cases around the world. Surprisingly, a lot in the United States, but obviously the most in China and Korea. And this is from the areas injected, nose, forehead, and glabella being the most common sites of blindness. This is the method that was favored, and that was obviously the retrobulbar method. And this was favored by, as you know, Jean Carruthers in 2012. I, at the time, had said, don't do it, it'll not work. I'd written papers saying that it's almost impossible anatomically, because of 3 layers of dura mater, that we should use the supraorbital method. And I had predicted that we'd probably spend 10 years and not have any cases. And this consideration was also taken by our Asian colleagues in China. They looked at this in 2019 and said, what are we doing? We have no cases reversed. And in the meantime, using the supraorbital method, we had almost, at that stage, 5 or 6 cases. This is an interesting case by Patricia Barbera in Argentina. And her patient had gone blind. She injected in the supraorbital area, just 1,500, as we had sort of said, and she had MRI, ophthalmic artery, central retinal artery showing blindness. Day 4, the patient could count fingers. Day 7, the patient was getting better. By day 13, the patient could see again. And believe it or not, Fernando Silkovich contributed to what he had learned in one of my books in Complications. Then, just before IMCAS this year, Jean Carruthers produced a paper. This is an important paper here with Rebecca Fitzgerald and also Katie Belancy, who was doing this. And they had said in it not to use the retrobulbar. The risk of globe penetration and sympathetic aplasia is too high. And they had said to use the supraorbital method. So you can see there in 8, where she had said, injectors are encouraged instead to use the supraorbital. That's where we were until this paper came out by a friend of ours in Ho Chi Minh City in Vietnam, and he had brought interventional radiologists together, almost like a stroke unit, and what they had decided to do was go in through the femoral artery, back in through the internal carotid, back then into the ophthalmic artery and into the central retinal artery. So that's the team sort of assembled, and these were his first patients. And when he had taken 10 cases, they reversed 8 of them. And we had brought him to IMCAS, which this is an IMCAS session, and this was one of his things. Could we have sound on that, please? Is there no sound? That's a pity. Do I do it here? Are there any AV people in the room? Anyway, I can take over from him. Where he had shown was that they had done 10 cases. 8 were
We put the microcatheter on the femoral artery. And from femoral artery, we go to the heart. From heart, we go to the internal carotid. And from internal carotid, we try to go to the brain and find the ophthalmic artery from the brain. And if you find the ophthalmic artery, you do the hyaluronidase directly on the ophthalmic artery. And at this moment, you can dilute your filler.
I can skip through that. So one of the problems that they found was that when the person restored their sight, the globe had got smaller. So as a consequence, some of them needed lenses. So the embolus hadn't just attacked the retina, but the whole eyeball had got smaller. So not all of his cases were totally successful. And
Recovery.
Then he came back again,
So
he gave us another lecture.
The classic treatment, like medicine, the hyaluronidase, the subcutaneous or retrobulbar alone, injection is not really effective. Why? Because the central retinal artery is stay in the middle of ophthalmic nerve and is protected by the dura mater.
So as a consequence of that, during one of the IMCAS sessions, we have a group, ISAC, that's from all around the world, from doctors from the United States, Britain, Ireland, Italy, and Australia, and European countries. And what we had decided to do was, just like a heart attack, you originally do CPR. You don't send to a cardiologist. So you obviously can palpate the supraorbital foramen and get the hospital ready. But instead of sending it to ophthalmologists, you should send it to the stroke unit. Most hospitals have stroke units that deal with, obviously, brain injuries from thrombus. Now, 34% of all vascular occlusions also cause CNS problems in the brain. So it's not just a straightforward visual blindness. 34%, that's 1 in 3, also have brain damage as a consequence. So we're trying to set up dedicated stroke units to deal with these problems. So trying to assemble a team just for blindness. In Britain, we've only had 2 blindness in the last 20 years. So, but there is strokes, obviously, every day. These are the first cases that Hung has sort of put through. And as I said, we had invited him a couple of years ago now to IMCAS. This is an IMCAS session, and he had given a lecture there. And we see from this that some of the patients that he treated were 10 days old, 2 weeks old, and they have an awful lot of visual blindness secondary to fillers in Korea and Asia, because everybody's injecting, including beauticians. And as a consequence, they have enough cases. They're getting 3 and 4 cases a week in that hospital, even though it's a dedicated tertiary referral centre. And that team have dealt with many, many cases since. I think they've dealt with about 60 cases. And in conclusion, they call this an IAT team, that's intra-arterial thrombosis. They don't use hyaluronidase per se. They obviously use thrombolytic agents as well. And that is the team that we had. There's a new method that's coming out also where you inject TPA and hyaluronidase after vitrectomy. So vitrectomy is the approach to the central retinal artery from the retinal side, not from the cannula. And this is the method they use here. So this has been tested at the moment. And you can see from this demonstration that you actually get an immediate effect. So this is something that we have teams all around the world working on. And it hasn't been totally decided who are the best people to deal with this. But we think because stroke teams are common in hospitals, that maybe is what's done. Now that's the end of my lecture, but stop injecting, central nervous system be involved, refer to, do a test of the eye yourself first, because when the ophthalmic surgeon sees it, he really wants to know where he's coming from. Obviously hyaluronidase you have in your fridge, go into the supratrochlear, supraorbital. It's easy to do, and thank you very much indeed.